say I was here, I'll be like, oh yes, I was, because he was wearing a gray shirt with blue underneath.
I got you marked down. You're here.
I'm just messing with you.
So let's take care of some business first before we get going. First things are, if you, for whatever reasons, did not make it last week to your lab sites, then you missed your first module exam. So you have until Friday of this week to get your module exam made up.
When we come this week, can we do it? Or do we have to do it at the time?
You got to do it at another time because you have a module exam this week as well and a lab on IVs. So you have to make it up outside of that time because that'll take away from your lab time. So
gotcha.
Right now there are two makeups going on. So if you're able to make it Friday morning to Perquimans at 10, there's a makeup going on there. And Wednesday afternoon at like 1:30 in Dare County, if you can make it there. So
you said Perquimans, 10 o'clock Friday?
Morning. Yep.
Okay, I'll be there.
Okay.
That's for the makeup of module 1, correct?
Yes.
Okay. And then I'm going Friday afternoon to Currituck.
Okay.
From 1 to 4, and that's when we have our other one. Okay. I was having
Okay, so today's session we have one chapter to cover, and that's on pharmacology. So we're gonna spend our time today talking about pharmacology and medications, and then in the lab this week will be IVs. So we'll start talking about we'll get you guys some hands-on time with IVs, and you also have your module 2 exam this week. So exam on chapters 7 through 10 this week, and then we'll go into IVs, getting you guys straight with that. I don't think I have anything else. We're getting ready to have a break. So we have class this week. We have no class next week. That'll be a break week for us because of the Thanksgiving holiday. So you guys get all caught up this week, and we'll give you a week off next week so you can not have to come to class or labs, but certainly keep getting into your books and reviewing your medication cards and those types of things as much as you can. All right. So let's talk about pharmacology for a bit. Because you guys have already had your medical terminology stuff, what does pharmacology mean?
The study of medicine.
The study of medicine, in the most basic of terms. And we're gonna get a little more into it. Other than the study of medicine, we're gonna talk about some other things. So you've got a couple big words in your chapter along the way, and they're farther deeper in the chapter. One is pharmacodynamics. The other is pharmacokinetics. Anybody want to take a stab at what either or both of those mean?
Kinetics means how a drug is absorbed.
Okay. The absorption, how the body metabolizes it, how it travels, what kind of time frames, those types of deals. So go ahead.
Pharmacodynamics is the effect of the drug and the mechanism of action.
Right. That's the pharmacodynamics. So what action is it going to have on the body? What effects is it going to have? This is what we want it to. This is the reason why we give it. So when we're administering medications to people, there's a few reasons why we give medications. So one is they have a problem and we have the fix for it, but we want to know what effects it's going to have on the body, what action it's going to have on the body. So every time we administer a medication, we should have an expectation of that medication. What is it? What are we expected to do? And then what it actually does, and if there are any side effects or adverse actions that we were not anticipating, then we need to document and deal with those. But we should have expectations of all of our medications, and that's why we're doing these medication lists and drug cards for you guys, so that you can learn about the medications and have that expectation when you're giving it. So where do medications come from? Anybody know?
Plants.
Plants? Where else?
Animals.
Animals are chemicals.
Okay, plants and animals. Any others?
And other chemicals.
Chemicals. Okay, so a lot of our medications occur. A lot of them occur naturally. They're found in plants, animals, minerals, from the earth, and then there are some that are synthetic. So these are man-made chemicals. This is where your high school chemistry class comes in to good use, or your mad scientist lab, so they can come up with these man-made chemicals, not only for good uses, but for bad uses. There are some man-made things that people are using recreational. Synthetic drugs that are being created. Anybody got any ideas on these?
Synthetic marijuana.
Synthetic marijuana?
Heroin, methamphetamine.
There you go. The little meth labs everywhere. This is their mad scientist thing coming out, where people are cooking up these synthetic things and creating these bad drugs. So those are having people are using them, and in most cases those all have negative effects on the body. With the prescription medications, whether they're naturally occurring or synthetically made, we're hoping that those have more positive effects on the body and correct some issues that the folks are having. Your book gives you a couple of reference materials. If you've never seen the physician's desk reference, it's a book that's about as thick as a Bible, or thicker. It rivals the Webster's Dictionary, and it has every medication known to man in it, I believe. So if you walk into a doctor's office or a hospital ER, I bet you could probably find one of these somewhere in there. But they use the doctors will use this if they need to look something up. A lot of things are in electronic form now, but the hardcover book version may still be laying around. So if you ever have a chance to get your hands on a physician's desk reference and look through it, it's quite interesting. It lists every medication and goes through all of the actions and reactions and potential uses and that sort of thing. Probably would be worth your time to thumb through that if you can get your hands on one. So let's talk about a medication profile. What information will we find in a medication profile?
Medication name.
Okay, the name of the medication.
How much? Is
Classification.
how much is in the vial per milligram?
Okay, so we've got a medication name, and we've got the classification. That's the drug class that it falls into. Heidi said how it's supplied. So that's the medication supplied. What's in the container? What's in the vial? What else do we have?
Mechanism of action.
Okay, and what is that?
It's how the drug is achieved its desired effect.
Okay, mechanism of action. So that's what we expect it to do, and the intended effects that it's going to have on the person. Keep going. What else?
Side effects.
Side effects. Those are good to know.
Contraindications.
Contraindications. When we don't, when we want to give this medicine, but we don't. Okay.
Indications.
Indications. That's when we need to give this medicine, when we should give it.
Drug interactions.
Drug interactions. How it interacts with other medications?
The route of administration.
Yes. How do we give it to them? Not all medications are given the same way, so there's many routes, and we need to know which one to use.
Dose and special considerations.
Okay. The dose, we need to know how much to give. Special considerations, because all medications are not created equal. And there's certain situations where we would give something and other situations we wouldn't. And I think there's only one left.
How it's supplied.
We covered that one.
What about the
Pharmacokinetics.
pharmacokinetics?
Yeah, the pharmacokinetics. That's the last one. How it's absorbed, how it's distributed in the body, how it's metabolized, and how the body gets rid of it. So those are all things for us to consider. But all of these things make up a medication profile. So let's go real deep into this. The medication name. How many names does a medication have?
It has a generic and a brand name.
Okay, a generic and a brand name.
Yeah, 3. And the chemical name.
There's 3.
Okay, and a chemical name. So we've got a generic, a brand name, and a chemical name. And what are the differences between those?
Brand name's going to be a trademark name. Generic is like what the drug is supposed to be.
Okay. Can you give me an example?
Acetaminophen and Tylenol.
Acetaminophen and Tylenol. So Tylenol would be the brand name.
Yeah.
Acetaminophen would be the generic name. Is it also the chemical name, or is there a different name for that?
I think acetaminophen is the chemical name.
Okay.
I don't think acetaminophen is the chemical name. I can't remember.
Yeah, I think the chemical name for acetaminophen is hydroxyphenylethylamide.
Say that 3 times.
Yeah, right.
Yeah. So acetaminophen is the generic name. And then what Zach said, that's the chemical name.
Shortened up, it's C8H9NO2.
There you go. C8H9NO2. So that's carbon, hydrogen, nitrogen, oxygen. So those are all natural things that are occurring there in Tylenol. So since we're talking about Tylenol, let's just keep using that for an example. So in most cases, we're probably going to be familiar with the trade names or the generic names more so than the chemical names. But let's talk about drug classes. Drugs are categorized in classes because there's a lot of different medications that do the same job. So anybody know what class Tylenol would fall in?
It's a NSAID, right?
It's a what?
NSAID?
No.
Tylenol is an analgesic.
Right. It's an analgesic. It falls in the analgesic class. And what are analgesics?
They are pain reducers or
Yes.
relievers.
Yes. So, and Tylenol is a pretty mild and calm one. So, but it falls in the analgesic class. We use it for pain reducing and for fever reducing. That is our intended uses for it. So those would be the indications. As you go down this profile, the indications would be pain or fever. That's when we're going to use it, because our expectation is that when we give Tylenol, it is going to reduce their fever and or lessen their pain. And that's what we're looking for to have happen. So does anybody know how Tylenol works, the mechanism of action?
Isn't it a COX inhibitor?
Not a clue.
Not a clue. Most people don't, right? All they know is that it's a fever reducer and an analgesic, so we give it for pain and for fevers. But they don't know what actual mechanism it has on the body. So, Mark, you said what? It's some kind of inhibitor?
Yeah, it inhibits the action of an enzyme called cyclooxygenase, which produces chemicals called prostaglandins, which are responsible for the pain perception in the body.
There you go. So that's the real scientific reason of why it works. And none of us care about that, right?
Except for me, obviously.
except for Mark. So we don't understand exactly why it works, because that's getting down to the chemical and cellular level. But we know what it's supposed to do, and that's why we're giving it. So from the pharmacokinetics standpoint, how does that work in the body with Tylenol?
Through the liver. It metabolizes through the liver.
Okay, we know that it metabolizes through the liver. So the liver is responsible for absorbing it. Once it circulates through, it absorbs it and breaks it down and sends it out for waste removal. So what are some special considerations then when we're administering Tylenol? Since we know what it's supposed to do, and we know a little bit about the pharmacokinetics, what are special considerations?
Severe liver disease, and other meds with acetaminophen
Okay.
in it.
So,
Basically, with other medicine with Tylenol in it.
okay,
Good God, Heidi.
spit it out. Spit it out. Okay, so using caution with patients that have liver disease. Also be aware of patients that have an alcohol abuse history, because what does alcohol do?
Kills the liver.
Yep, damages the liver. So we know that alcohol consumption is also metabolized in the liver. So we don't want to overload alcoholics with Tylenol, and we don't want to overload people that have liver disease or liver damage with Tylenol. Any other special considerations? What in the world?
If patients are anemic, if they have a low platelet count,
Okay.
Pregnancy.
Pregnancy, what about it?
There's certain medications you can't give to a pregnant patient due to the fetus.
Okay,
It
so
might fetus.
so we'll get into that in a little bit, but all medications come with a classification for pregnancies, and we'll talk about how that scale works here in a little bit. So all medications are going to come with consideration for pregnancies. Okay. Does anybody know what side effects Tylenol has?
allergic reaction, nausea, cramping.
Okay. Pretty much every medication has two side effects that you'll see, and that's nausea and vomiting. So any medication we talk about, that's a good place to start. Side effects are nausea and vomiting. Anybody? Does anybody know the routes of administration for Tylenol?
You can give it orally.
Okay, orally
And a suppository.
and in a suppository form. Everybody's favorite.
Oh yeah.
It comes pill form and liquid.
Okay, so it's supplied in pill form and liquid form, and it is administered orally and rectally. Okay, so that's essentially a medication profile there, and that's what we would talk about. We picked Tylenol because you guys brought it up. That is one of your medications that we will get to down the line. so you'll cover that more in depth in your medication card. But that's essentially it. Those are all the things that you should be covering on your medication cards, and all the things you should be thinking about when you're giving different medications. There is a nice table in your book on page 260, if you're referencing that while we're going along. It talks about controlled substances. So all of these medications are regulated by the federal government. That the FDA regulates all prescription medications and most over-the-counter medications. So they have certain controls over these things, and this table of controlled substances you guys are quite familiar with, I'm sure, and you know that there's five different categories. They're in schedule categories, so schedule 1 through 5 of controlled substances. And how does this scale work? Is 1 more severe or less severe than 5?
More severe.
Okay, so schedule 1 substances are the most severe, and schedule 5 substances would be the lesser of the medications. So Tylenol is your schedule 5 stuff. That's your over-the-counter medications that are controlled substances. So that would be stuff that you can walk in the pharmacy and buy over the counter. Your schedule 5 things. Schedule 1 things are going to be more severe stuff and mostly illegal stuff like heroin and LSD and things like that. So a lot of our pain management medications are going to fall into the schedule 2 category, maybe schedule 2 to 3 is where they. What's that?
Like fentanyl?
Yeah.
Fentanyl and morphine? So what's then 1? Like Dilaudid?
So morphine is a schedule 2, and things like that. But
So what is it, like your well, no.
benzos are schedule 3.
Really?
So yeah. Well, actually, benzos are schedule 4. I'm sorry. The benzos are schedule 4.
Wow.
I think the difference between Schedule 1 and Schedule 2 is like Schedule 1 isn't used in the medical field. It's just like all recreational. And then Schedule 2 actually has a medical use.
Right.
Gotcha.
Yes. Schedule 1 drugs don't have any medicinal purpose. They're mostly like illegal narcotics.
Yes.
Okay.
So those are and that's the top of the scale. That's going to be your heroin, your LSD, your meth type of stuff. And then
I got you. I'm sitting here thinking about like ketamine and
right.
succinylcholine, rocuronium, that would be your schedule 1, but okay. So they would use it.
No, they're most of those are going to fall in schedule 2.
Okay.
And then schedule 3 anabolic steroids. Codeine, Vicodin, things like that are schedule 3s. And then schedule 4, your benzos, your barbiturates, some other steroids, that type of stuff. So your Versed and your things like that are going to be down there. So it's a nice list on 260 for your controlled substance schedule. I would strongly encourage you to differentiate between the 5 schedules because I feel like you could have some really good test questions from that. If you flip over to 262 on your book, this is where you get your categories for pregnancy. And we hit on it earlier, special consideration. A lot of medications can be given to adults that they use extreme caution or don't use with pregnancies because of damage to the fetus. So they have 5 categories for these medications. And again, I would highly encourage you to learn these categories of when they can be given, or cases where they can or should not be given with pregnancies. So these are A, B, C, D, and X. Those are the 5 categories for pregnancy. And the one that is really important is the X category, because that is a do not give at all.
I'm guessing because it crosses the placenta.
Well, yeah, and it will cause damage to the baby. So so in the X category, it's pretty much, if we give this drug to a female that's pregnant, it's going to damage the baby. They can almost guarantee it. So all right, so category A medications are fairly safe, but category X medications are definitely not. And then B, C, and D have the varying degrees between safe and not safe. So you guys can study those up and look at that. Another one of the things that hopefully you guys can be profiling in your medication list is how it is used, or how it ranks on this pregnancy scale with those 5 categories. So something else to keep in mind there. Another class of people that medications have different effects on is the geriatric world. So what are some reasons why medications affect geriatrics differently than everybody else?
Medications they take, they're sometimes smaller, more, can't think of the word, but they metabolize maybe more than the younger people.
Okay, so
That's good.
drug interaction, because they have a whole grocery bag full of medications that they're taking.
But they have no health history.
Yeah, they have no problems at all. So that's one reason. You have to look at all of this drug interaction because of the whole laundry list that they have. Heidi talked about metabolism. What usually happens with metabolism in older people?
Their organ systems aren't as effective as an adult or a younger person. So like the kidneys or the liver, wherever the drugs metabolize, they could have a lot more conditions that you have to consider than like your normal aged person.
Okay, so we would we expect their metabolism to be better, slower, faster? How would we expect it to be?
Slower.
Lower.
Slower and not working as well.
Mhm.
So when they take a medication that says that, it lasts 4 to 6 hours in these geriatric patients, it may not last 4 to 6 hours. It could last hours longer, because their body is a lot slower at metabolizing and using it and getting rid of it. This is where they actually become, if they take some medications over long periods of time, they may become toxic if their body is not metabolizing it well, or being able to get rid of it. So, some things to consider there. Okay, we covered the names. So again, be familiar, trade names, generic names, chemical names. Um, expect at least 2 names for every medication. You guys should be familiar with at least 2 names for just about every medication. We know they have at least 3 names, so we're gonna, in most cases, not know the chemical name, but we if you only learn one name, some people may talk to you and use the other name, and then you won't know what medication they're talking about. So I would encourage you with all of these medications to, learn at least 2 names for it. And then we're getting into how medication, what form medication is developed into, supplied, and comes in. So your book talks about medication solids, liquids, semi-solids, and gases. So those are four medication forms of how they're supplied. Solid form would be like what?
Your pills.
Okay, pills and tablets, things like that. Those are solids.
Patches.
Patches. The patches are going to fall into the semi-solid form. So solid form, mostly just going to be pills, tablets, capsules, those types of things. The semi-solid, that's where your patches are going to be. Also going to be lotions, creams, gels, those types of things.
But basically, anything applied topically is going to fall under semi-solid.
Semi-solid is mostly going to be a topical application, and your book uses lotions, creams, gels, ointments, and patches. So basically, anything you rub on the skin, that's a semi-solid. Whereas the solids are going to be your pills, tablets, capsules, those things that you would swallow. Solids also would be fine powder form. Anything in powder form, like a BC or something like that. That would be a solid as well. Liquids, it gives you what, 5, 1, 2, 3, 4, 5, 6 different forms of liquids. So these are going to be some things that you will need to differentiate and potentially test question worthy there for you, which would be your book uses these as suspensions, tinctures, spirits, elixirs, syrups, and emulsions. Okay, they define each one of them. And that's going to be some good study material for you. So if you're not cool with those, then that would be a good place to spend some time to work on figuring those out. Tylenol, we talked about earlier. Tylenol comes in the liquid form, and of these 6 different ones, anybody want to take a stab at which one Tylenol would be?
Suspension.
It does come in a suspension form, and that's pretty easy because you can read it right on the bottle. So usually, if you get Tylenol or ibuprofen in that liquid form, it may be a suspension that you would do it. A lot of liquid cough medications would be the syrups, because they always refer to it as cough syrup, and that would fall in the syrup category. So spirits, those are the ones everybody like because they usually have alcohol in them. So let's
Is there
do
really like a big difference between syrups and elixirs? I'm reading their definitions right now, and they're almost identical.
almost identical, right?
I think it's just the viscosity. Syrups are thicker than elixirs. I don't know.
Yeah, I think that's probably it. Um, that's going to be the difference, and that's going to be the difference in a lot of these. Is just the way the liquid dissolves, or the thickness of the liquid, or what's in it. Like the spirits, the only difference with the spirits is it has alcohol in it. So there's very very small distinctions, but they could be worthy of knowing. And then the last form is gases. So you guys have a couple of gases in your formulary. One you're familiar with, one you're probably not. Anybody want to take a stab at what they are?
Oxygen.
Okay, oxygen is the one you're familiar with. That's the gas that we use the most. There's also an analgesic gas that is actually in the AEMT formulary. And your book mentions it here in this section. You'll have it on your drug list by the time we're finished, but that's nitrous oxide. Okay, so used in dental mostly, dental work, nitrous oxide, but it is making a very nice comeback in the EMS world. So they're using that for pain management, and it's administered by it's actually self-administered by the patients. You turn it on and give them the mask, and they hold it there until they pass out. And that's the actual dosing. Let them hold the mask, and when they've had enough, then they'll just go to sleep and drop the mask, and there you go.
So that's acceptable to put on our drug card for it?
Well, you need to do your research and see what the dose is, but that is the actual administration of it. Okay, let's talk about drug classes. A lot of drugs are classified based on their mechanism of action, based on their pharmacokinetics and pharmacodynamics. And so they create these classes of drugs. And if you, in some cases, if you don't know what a medication is, if you know the drug class, you at least have some idea about what it's doing or what it could do, what it's supposed to do. And in other instances, you may be able to just look at a name of a medication and determine what class it's in based on its name. So those are, just some cool things to know. So, nobody's going to know every single medication that's out there. And when you look at a bottle, especially when the people throw you a grocery bag that has like 37 bottles in it, and you're looking through all of those medications, you're not going to know necessarily every single one, but in a lot of cases, based on the names or the classifications, we can come up with some ideas about what they do. So
I usually go with the prefix and the suffix. Sometimes is what helps me a lot.
Yeah. So, the way these things are named, and a lot of drug classes have similar names. So those are going to be some good indicators for what class they're in, and if you can figure it out, and then what effects these may have without actually knowing anything specific about the drugs. So your book starts with the autonomic nervous system classes. So remember, we have the sympathetic and the parasympathetic nervous systems. And so we have sympathetic and parasympathetic medications. So 2 words that you'll see for each one of these classes. You'll see that the words, like Heidi said, with prefixes and suffixes, the words are going to start with those systems. So you'll see a sympatho and parasympatho as the beginning of the words. And then the ends of the words, you're going to see lytics and mimetics. Okay. And that works for both systems. So you'll see sympathomimetics and sympatholytics, and you'll see that in the para as well. And they have exactly the opposite meaning. So sympathomimetics, anything that you see mimetics, that mimics that system. So those drugs are going to have an action on the body that mimics what that system is. So in the sympatho system, what does that system do to the body? What effects does that system have on the body?
Fight or flight.
That's your fight or flight system. So what is the body going to be doing when that kicks in?
Pumping adrenaline.
Okay. And what effects are we looking at? We're looking at increase in blood pressure, increase in heart rate, increase in respiration, more. Most things you're going to see go up with that system. And so if you have a medication that is a sympathomimetic, that medication is going to have that effect on the body. So even though that person may not be in the fight or flight mode, that medication, when we administer it, it's going to put them in that, it's going to put their body in that fight or flight mode. So it's going to do those things to the body. It's going to increase blood pressure, increase heart rate, increase respirations. So sympathomimetics, they are vasoconstrictors, bronchodilators. So you get more, right? So with the lytics, the sympatholytics, those medications are going to inhibit that system. And so that's going to be your difference between those. So mimetics mimic the system and lytics inhibit the system. So that'll block that system from kicking in and keep it from going into that mode. Does that make sense? Yes, no, maybe?
Yeah.
Okay. So now you guys get the job of giving me an example of each one.
Epinephrine is going to be your sympathomimetic.
Okay.
Beta blockers are a sympatholytic.
Okay. Does anybody know what beta blockers do to the body?
They bind to, I believe, beta 2, maybe beta 1 and beta 2, I don't really know, receptors, and prevent sympathetic hormones and neurotransmitters from having their effect.
Okay. So specifically, beta blockers keep your heart rate down. They affect heart rate directly, and they will not let your heart rate go up. And because your heart rate cannot increase, that's what keeps your blood pressure down. All right. So that's how these words come together, and hopefully you guys are starting to see some of these puzzle pieces, and they may come together for you. But those two systems, and those are where you're going to see the memetics and the lytics that are in those two systems. So anything memetic is going to mimic that system, and anything lytic is going to inhibit that system. Okay. We talked briefly about analgesics earlier. So analgesics, again, are for pain management, pain reducers. You guys have a few analgesics in your AEMT formulary. We haven't gotten you the entire list yet. But right off, are you guys familiar with any of those that you have?
Acetaminophen and ibuprofen.
Okay, acetaminophen, ibuprofen.
I think aspirin has some analgesic effects, but that's not what it's used for.
Right, that is correct. Aspirin technically falls into it, but that is not our indication for use with aspirin. Our indication for use with aspirin is chest pain, but we're giving it for a platelet inhibitor reason, not for analgesia. There's one more big one in the AEMT world. Anybody familiar with it or not? I'll give it to you if you don't know. And then when I say it, you'll say, oh yeah, come on, Heidi, what is it? You know it.
I don't want to get it confused with my medic drugs, but is it Toradol?
It is Toradol.
Shit. Oh,
See?
sorry.
Yeah. See? Yeah, we recorded that, by the way.
Sorry.
Yeah, Toradol it's a more high-powered NSAID.
So it is an intermediate drug.
It is.
Because I am having trouble, like, But
Yeah.
yeah. Okay. Cool.
I understand, but yeah. So it's a more powerful NSAID than ibuprofen, and so you guys will have that in your formulary, and it's coming in one of the later lists for pain management.
Ketorolac.
That's not in this list.
Gotcha.
All right. So you see the acronym NSAIDs a lot. Just for clarification, anybody want to tell me what NSAID stands for?
Non-steroidal anti-inflammatories.
Drugs.
Yes, non-steroidal anti-inflammatories. So that's your ibuprofen-based medications. So there are some, over-the-counter ones you can buy, which is ibuprofen. And then there's a lot of different varying levels of prescription ones. We talked about Toradol. That is one of those that you guys can use. Naproxen is another one you may have seen or heard. That is a prescription pill form medication. So those types of medications all fall into the NSAID category. So what's important to know about NSAIDs? Special considerations, contraindications. What are some good things to know about NSAIDs?
Again, go back to the Tylenol. Special considerations.
Yeah. What are NSAID special considerations specifically?
Oh, liver damage, alcoholics.
If they're going to be operated on within a certain amount of time after giving it.
That's a
Okay.
huge contraindication.
Okay, so with NSAIDs, our main deal is worrying about bleeding. So if we're anticipating them having to go to surgery, then giving NSAIDs is a bad idea. If these folks have GI tract bleeding or ulcers, things like that, then giving large amounts of NSAIDs is going to be a bad idea because it's going to increase GI bleeding. So be cautious in folks that have a history of GI bleeding, or if you're anticipating in their continuation of care that they are going to need surgery, then be very cautious or withhold your NSAID administration, because it's going to increase bleeding and most likely delay surgeries if you give it. So that's our big issue with Toradol, is that it's a fairly decent pain medication, but it is an NSAID, and if we're using it for trauma purposes, it may be a bad idea, especially if people need surgery. So we don't usually give it for like broken bones and things like that because of the bleeding issues. It's more administered in the medication world for things like kidney stones or stuff like that, where we're pretty certain we know what the problem is. They won't need surgery right away, and we can do that. All right. You guys good with all these? Good.
Yep.
All right. They go into the class of, we talked about the analgesics. We talked about NSAIDs. We talked about the narcotic schedule medications that we have for analgesics. So there's a lot of different, the big category analgesics, but there's a lot of little subcategories underneath of that. Your book goes into anti-anxiety, sedative, hypnotic type stuff. One of those drug classes is barbiturates. Another one is benzodiazepines. So, unfortunately, at the AMT level, you really don't have anything in these worlds for you. So, but they're good to know, especially when you're out in the world dealing with your patients. So just because we're getting you into the AEMT world, and just because it's not in your formulary, does not mean that you don't need to learn these medications. Because when you come up on a patient who has these things at home, it's good for you to know what it is, what effects it should have on them, and that way you can maybe make some really good educated guesses on what's going on with them. Maybe they did overdose on their beta blocker, right? So what kind of things would you expect to see if they did overdose on their beta blocker?
It would be super bradycardic. Their heart
Okay.
rate would be.
Yes, super low blood pressure.
Exactly. These people could be bradycardic and hypotensive, and it's not because they're having any kind of cardiac issue. It could only simply be because they forgot that they already took their beta blocker and they took it again. Or it could be because their metabolism is so slow now in their elderly age that their body is not using it and getting rid of it, and now they're a little toxic from it. So these things would be good to know and good to expect if you're dealing with that type of patient. So don't discard medications just because you can't use them or just because they're not in the AEMT formulary, just like barbiturates and benzodiazepines. You should know what they are. You should know what effects that they're going to have on the body, and you should start to learn some of the names of them. Okay. So in the paramedic world, we're carrying benzodiazepines on the truck. The medics have them, they can use them. So if you guys aren't familiar with them, and I know you are, so give me one benzo that's on the truck.
Versed.
Versed, probably the most popular, the most prominent. Versed is on the truck. Okay. So what do we use it for?
Pain, like open fractures, pain, to maybe behavioral
What's the number one use for Versed?
pain.
Nope, not pain.
Seizures.
Who said that?
Callie.
What is
Callie?
it?
Seizures?
Seizures.
Oh, seizures. Yeah. Forgot all
Seizures,
about
right?
Yep.
That's the number one. We used to use Valium for that, but now Valium is unavailable. So now Versed is the number one treatment choice right now for seizures. It does also have sedative properties and pain control properties down the road, but whether or not your protocols allow you to do that is up to them. All right, but good to know, good to be familiar with. You guys need to learn all you can about these medications, and they're more and more popping up all the time. You see the commercials for them and on TV of, you know, all of these different medications and what they do. So keep learning. You'll keep seeing them. If you don't know what the medication does, it is quite all right to look it up. I do that a lot. You know, when I run across medications that I haven't seen before or don't know what these names are, not familiar with, I will pull my phone out, type it in, and get a real quick read down on what it is, what class it's in, what it's used for, dosages, that type of thing. So quite all right to do that. So moving on, there's stimulants, there's depressants, there are anticonvulsants, which we were just talking about, and then there's some psychotherapeutic drugs. So a bunch of different classes there. Stimulants and depressants, what are they typically used for?
Stimulants are used a lot for like ADD or ADHD medication.
Okay. Do you know a medication that falls into that category?
Adderall, Vyvanse, Ritalin.
Okay, so you know a lot of those.
Yeah.
You've been buying those on the black market there, Mark?
No.
Okay. Well, just so you guys know, those are some examples. But right now in the world, Adderall is a very hot button medicine in recreational use. So there are a lot of people that are buying this. Typically, somebody will get a prescription for it, and then they will start selling them illegally because they can, and they can make some good money doing it. But there are a lot of people that are buying this, and you will see a lot in the college student world, especially around exam time and things like that. They need some extra energy. They need some extra focus. And so supposedly Adderall will give you like a sharp mental focus, and it will amp you up so that you can stay awake longer, things like that. If you're not an ADD type of person, if you're like a normal type of person, that's the supposed effects that it has on you. So this is very, very common in the recreational world. Anybody know anything about that? No?
I know that people use those for not for studying and stuff too, for like
Yeah.
partying.
Yeah, partying. Exactly.
Same with the anti-anxiety medications like Xanax and Klonopin.
Yes. Okay, so depressants, what's an indication of use for depressants?
It's gonna be like your Valium and Xanax, stuff like that.
Okay. So different different medications and drug classes in the depressant world. You're going to use you could use some benzos, you could use barbiturates, you could use narcotic stuff, and there's different indications for it also, treating anxiety, depression, stress, sleep disorders, those types of things. So those things, they're intended to basically slow you down, calm you down, and relax you. That's what they want to have happen. So those medications will do those types of things. So slow you down, calm you down, make you go to sleep. People that are taking these medications, that's what you would expect to see from them. Again, the anticonvulsants, we talked about those. Typically in the EMS world, we had two medications, which are benzodiazepine class medications, and we used to carry diazepam, which is Valium, and we have always had Versed, which is midazolam. So now the Valium availability has gone away, and most people now they just have Versed, and they're carrying that for their anticonvulsant medication. Caitlin, are you still here, and will Valium ever come back?
I'm still here. Valium, I guess because it's supplied more in the Carpijet,
Yeah.
is I think the issues that we're having with getting it. I know that in Brooklemans we've been paramedic for 2 years, and we have yet to carry Valium, and that's mainly the reason is the packaging issue.
Right. So, in the last couple of years, more so than I've ever seen, a lot of medications have become unavailable or back ordered, and so EMS is having to switch to different alternatives because of availability of medications. So just be aware of it. They're now writing. I know Chowan wrote some protocol changes, and they put, in a certain drug class, they put 3 or 4 different options because of availability to these medications. So they, in the analgesic world, typically the medics were carrying morphine and fentanyl, and now because of availability and stuff, they went through, they added Dilaudid to their list and different things. That way they don't have to come back whenever there's an issue with availability. They don't have to come back and rewrite protocols or write in treatment options and that sort of stuff. They went ahead and did a blanket thing, gave a lot of options. And so now it's just up to the agency and what's available and what they can order and use. Okay, so a few more drug classes. They have respiratory medications, cardiovascular medications. In the cardiovascular world, there are tons of little subcategories. They look at anti-dysrhythmic medications, antihypertensive medications, antiplatelets, anticoagulants. So all of these little classes are working on that specific thing. So antidysrhythmic medications, these are all the medications that look at your heart rhythm, and if you have an irregular heart rhythm or a not normal heart rhythm, then these antidysrhythmic medications are all geared towards making your heart rhythm normal again by whatever mechanism of action that they have. So good things to know, good, all of these little categories, and it's good to start putting names of medications into these categories to help you guys hopefully draw some good pictures and have some things come into play. Antiplatelets and anticoagulants, what is the difference between the two? Hello? Somebody watching TV?
Anticoagulants, that's like your blood thinners,
Okay.
like for patients with like AFib. So they're
Okay.
gonna probably like cardizem, cardizem is an antiarrhythmic, correct?
Right.
Okay. So they're gonna take that.
So
Your
what are some examples of anticoagulants?
Coumadin.
Yeah, Coumadin.
Okay. Coumadin.
Oh shoot. I see them on TV all the time.
Xarelto.
So, yeah.
Xarelto. Yep.
Eliquis.
Eliquis. Yeah, these are the ones you see on you see all these on TV all the time, and they talk about treating people with people that have AFib, and they they have these medications because AFib has an irregular heartbeat, and one of the things that AFib makes you susceptible to is blood clots, which will cause strokes. So these anticoagulants are designed to keep the blood from clotting, and that will hopefully prevent you from having strokes. So in the simple terms, that is the thought process. And so that's what these medications are doing. So people that are on warfarin, which is Coumadin, or Xarelto, Eliquis, Lovenox, any of those types of things, that is these anticoagulant medications that will hopefully prevent blood clots and keep you from having strokes. What about the antiplatelet?
That would be like an
Antiplatelet agent inhibits the platelets sticking together.
Okay. So what's an example of that?
aspirin.
Plavix.
Plavix and aspirin. So essentially the anticoagulants and the antiplatelets in the big picture are doing the same job, but they're doing it in two different ways again. So the antiplatelets, they inhibit platelet aggregation, which means this is where, like with the aspirin, they make the platelets slippery so they can't stick together and bind and create that clot. Where the anticoagulants are interfering with other steps in the clotting process and keeping those clots from forming. So again, minor distinctions between them, but they're doing the same work. And then the drug classes finish out with diabetic medications and immunosuppressant medications. Those are a couple other classes here. People that have autoimmune diseases, those immunosuppressants, they are designed to keep the body from attacking its own tissues. So hopefully that'll work with those autoimmune diseases. And then you guys should be familiar with diabetics, because all the ones that aren't hypertensive or diabetic in Eastern North Carolina, and then you have the lucky winners that are hypertensive and diabetics in Eastern North Carolina. So you should have a good handle on some of the diabetic medications. Besides insulin, what are some other choices for diabetic medications?
Glucagon, D50.
Mm-hmm.
Orange juice.
Those
I'm
are the
just
two that we carry.
Yeah.
What about some prescription diabetic medications?
Oh, metformin.
Metformin,
Insulin.
Glipizide.
D50. Glucagon.
glucophage.
Glucophage.
Yep.
Would that be glucagon?
No, there's glucagon and there's glucophage.
I've never heard of that.
Look them up.
Interesting.
Glipizide.
I've
Lipizide.
heard of glucagon, yes, I've heard of, but glucophage?
Yep.
I gotta look that up.
Well, look it up.
I am.
You got a phone?
I am. Thank God for Google.
Oh. Because you already said it once. This is where those two names come into a play. Did you look it up, Heidi?
No, I'm trying to think of what I said.
You said metformin,
Oh,
and
metformin.
I said glucophage.
Oh, let me guess. The glucophage is the not the brand name, but the chemical name.
Nope.
Hold on,
Glucophage is the brand name. Metformin is the generic name.
generic name. Okay.
Yeah.
Yep. There you go.
It's the same medication. So once again, so you recognize the metformin, and then I said the glucophage. We're talking about the same medicine, but if you don't correlate those names, then
I honestly don't know that I've ever seen it called that, but I mean, or I've just never paid attention. I just see metformin and just roll with it, but okay.
Mm-hmm.
Learn something new.
So that's why it's important to take the time and try to develop more than one name for these medicines. But there you go. So let's talk real quick about medication packaging. Now, we talked about the forms that the medication comes in: solids, liquids, semi-solids, gases. What about medication packaging? That's the containers that this medication is in.
Which medication?
Any of them.
Or you're talking in general?
Yeah, in general, what are some packaging ways?
They come in vials.
Pre-filled syringes.
Okay. Vials, pre-filled syringes,
cups, pills, tablets, paste.
Those are the forms. But the packaging, your book gives you about 4 different packaging forms. So we said vials, we said pre-filled syringes.
Ampules.
Ampules.
Ampules, that's the.
Okay, there's 2 others.
Nebule.
A nebule. Anybody know what a nebule is?
When you give A and A.
Okay.
It's a with the mist with the when you use O2 nebulizer.
Yeah, that's it. That's a nebule. Those little plastic long things that the albuterol and the Atrovent are in, those are
Yeah.
nebules. And then there's one more.
Mm.
Non-constituted medications.
Yes. Now, which one of your medications comes this way? Do you guys know?
Which medication? I just checked out.
Glucagon.
Glucagon. There you go. Non-constituted packaging. So the glucagon is supplied this way. So that means there's two vials. One has powder in it, one has liquid in it. And when you want to administer this, you have to draw up the liquid and inject it into the powder and mix it up, which is a reconstitution. And then you draw that up and administer it.
Wait, Solumedrol's like that too.
Solumedrol is that way as well. Yes. So those are non-constituted medications. Nebules is going to be your albuterol and your Atrovent. Yeah, hang on. There you go, Zach. Sorry. Too many moving parts here. So that's how it's supplied. Those are the ways that you'll see it packaged when you get it. The ampules or the little glass ampules that you break the top off. What is the key to ampules for drawing that medication up?
You use a
Filtered syringe.
filter.
A filter needle.
Filtered needle.
Absolutely. You need to use a filter needle. And what's the reasoning for that?
So you don't get glass shards.
Yes. We don't want
Brian,
to.
you cut me off.
We don't want to draw up glass and inject glass into people. So we use a filter needle to draw the medication out of the ampule, and then we discard the filter needle and we put an injection needle on so that we can, or we just, if we're going to use a needleless operation. So, but all we do with the filter needle is draw the medication out, and then once we have it out, we discard that filter needle so that there's no potential for us to inject glass into people. Okay. Let's talk about administration routes for medication. What are the routes of administration?
Mouth, IM, IV, rectal, nebulized, inhaled, nasally. I think I got them.
Almost.
I'm missing one.
Okay. So Heidi said mouth, which we refer to that as orally. And
Orally.
we document that as PO. Okay. Then she said IM. What is IM?
Intramuscular.
Intramuscular. So that is an injection.
You have to double, in some medications, you have to double your dose.
Not with IM.
Not with IM?
Not with IM.
You
What else
sure?
what else did you say? You said inhalation.
Inhalation, which is your neb.
And how do we document inhalation? What's the abbreviation?
NEB.
Nope.
IH.
IN.
Oh.
Inhalation is IN. Intramuscular is IM. And then you said nasally, so we can administer medications through the nose. What do we need to do that? What's the device?
Atomizer.
Yeah, you need that nasal atomizer, that little cone-shaped device you screw on. And how do we document that? Does anybody know nasally?
I do NAS.
You do NAS? Is that approved?
Or I just write out a nasal.
Yeah.
I mean,
Okay.
and I mean, honestly,
You said rectally. That's a way to give it, usually in suppository form. Can you do liquid form rectally?
yes.
Yes, with a syringe. So much fun. No needle though. You don't need a needle. Um,
Ouch.
boy, that would be bad, wouldn't it?
That would hurt.
Yeah. What else
Some
did you
people
say?
get into that.
And then IV, of course.
Okay, IV. All right, so there's a few more routes. What are they?
IO.
IO,
IO, yes. IO. It's off the work I go.
IO, and IV, very similar. Keep going.
Dump the medication down the ET tube.
Okay,
Okay.
down the ET tube, Brian says.
Yeah.
So we can give a few medications, not all, but we have a limited list of medications that we can administer down the ET tube. And if we do that, does anybody know what we need to do with those medications?
Double 'em.
The dose gets doubled down the tube. Yes. So we can do some medications. We'll cover those later down the tube, and we would double the dosage for that. Any other routes? There's at least one more.
Topical.
Yes. So don't forget your patches, your medication patches. Those are we call it transdermal because it's across the skin. That's how it goes. So your nitro patches, your fentanyl patches, your different medication patches that you have people that put 5 or 6 on at a time, or they're sucking on them or whatever they're doing. You know the people.
Oh, I do. I've had 1 or 2 of them.
Right. So think about the ways that things enter the body. They enter through ingestion, they enter through injection, they enter through absorption. And so this is how we are going to introduce things into the body. So we can ingest, we can inject, we can absorb, those types of things. Could we potentially be affected by medications that we administer to patients?
Yes.
Yep.
How so?
Get some nitro paste on you.
Yep. That's right.
Okay.
How fast you fall out.
Get some nitro paste on you. What else? Any other examples?
Inhaled treatments.
Inhaled treatments. Okay, we talked about nitrous oxide a little bit earlier, and what would happen if you guys are administering nitrous oxide to the patient in a very tight space or a closed environment? The potential for you to inhale nitrous oxide there also?
Mm-hmm.
Shoot, yeah, you both be back there sleeping.
Good night.
Medication storage is an important thing for us. Okay. And most medications, if you look at the profile, it'll give you the climate that it should be stored in. It'll give you a temperature range, and it'll give you any special instructions about it. Most of our medication is fairly stable. We have a couple of exceptions. So you should be mindful of those and be aware of them. What's our most unstable medication that we have?
Cardism, isn't it?
Not at
Or
this
warm
level.
fluid?
Not at this level.
Not warm fluids?
Not AMT
They're not-
level. AMT.
Nitro.
There you go. Nitro. The most unstable medication that we're carrying is probably
It's gotta stay
nitroglycerin.
dark. It's got to stay dark and covered.
Okay, so nitro is highly unstable. It comes in a brown bottle, which is because it's light sensitive. So all medications that are light sensitive, you'll usually see them in brown glass. Nitro is also temperature sensitive, as a lot of medications are. So if you store it outside of those parameters, what effects is it going to have on the medication?
Going to weaken it.
Okay, weaken it. It will lessen the effects that we expect to see. This is why I told you guys, if you administer nitro to a patient, what do you expect it to do?
Have a line in place and have them on the monitor.
No,
Decrease
if
blood
you
pressure.
administer nitro, what effect do you expect it to have on that patient? What is it supposed to do to them?
Decrease their blood pressure.
Decrease their
Basic
blood
nitro.
pressure.
Decrease
what-
their heart rate.
No, it won't decrease their heart rate, but it will decrease their blood pressure. So we expect it to lower their blood pressure. What side effect do we expect it to give them?
Headache.
Okay.
Maybe a little lightheaded, flush in the face.
Okay. So if we administer nitroglycerin to a patient and none of those things happen, if their blood pressure does not drop, if they don't get a headache, they don't get lightheaded, they don't start to maybe necessarily feel better, what is the conclusion that we should probably draw?
Meds out of date. It's been exposed to heat, been exposed
It's
to
no
light.
good.
Yeah, it's not good.
Yeah, so our medication is probably no good. And the reason for that is these storage conditions. It's probably been opened before if it's the nitro tabs. It's probably been exposed to heat or light, and it has lessened the effects of that medication and made it ineffective. So something to be aware of. That may not always be the case, but in most situations, I would say if you give nitro to somebody, you don't see their blood pressure drop, they don't complain of a headache, I would say your nitro is probably no good. Okay. What is the number one reason not to give a medication to any patient? Any medication to any patient?
They're allergic to it.
There you go. Number one contraindication to all medications is hypersensitivity. That's the buzzword that your book uses, the bold print word, hypersensitivity. That means that they're allergic to it in some fashion. So if you see every medication you deal with, that's going to be the number one contraindication is hypersensitivity, and that's for all medications. Although there are a few medications that nobody is allergic to, like oxygen. So you don't have to worry about it, but in all
Now I'm
medications.
going to have a patient tomorrow that's going to tell me they're allergic to oxygen.
Yeah, well, I hope you believe them.
And then I'm going to text you.
Yeah, well, believe them when they say it, okay? So hypersensitivity, the number one contraindication for all medications, and the number one side effect that you will see listed for all medications is nausea and vomiting. That is a side effect that is listed in every single medication in the world is nausea and vomiting. All right, guys, before let me give Caitlin a chance here if I missed anything or she's got anything to add before we cover your medication list this week.
No, all good here.
Okay. She said we're good, so we're good. Now, you guys had 4 medications this week, so let's take the easy one first. Somebody want to tell us about oxygen?
What do you want to know?
I want to know the names, the indications for use, the contraindications for use, the dosages, the routes. I want to know it all.
Route's going to be nebulized. Well, is that considered nebulized? Nasal cannula.
Oh,
Well, then what are you looking for?
what's the route?
Inhalation.
Inhalation.
Thank you.
Way to go, Brian. So the route is inhalation. It's only nebulized if we mix a liquid with it. That's what nebulizing is. So,
Right.
So as long as it's just the gas, it's inhalation. Okay. So the name is oxygen. Is there any other names for it? No.
O2.
No. Okay. So the name is oxygen. The route is inhalation. What is the dose?
Depends upon how you're using it.
Mm-hmm. So tell me all of them.
Let's see. 1 to 6.
Cardiac arrest is 100%.
Okay, let's do dosages based on devices and liters per minute.
Nasal cannula is 1 to 6 liters per minute.
Okay, we got a nasal cannula.
Your mask is 8 to 15, liters per minute.
That's a non-rebreather mask.
When you're doing,
What do you run a BVM at?
15.
yeah,
15.
15. Okay. What about nebulizers?
Till it starts smoking around 6.
Hey, most of those are going to be 6 to 8. CPAP.
oh,
You start with the lowest setting that is actually effective to the patient.
Okay, that's for the pressure. That's the PEEP settings.
yeah, don't you go
Oxygen.
according, yeah, don't you set it though?
Oh shit! It's set to manufacturer's specification.
There you go. That's the tricky answer there for CPAPs. CPAP delivery devices are different, and they, each one may have a different O2 requirement. So don't confuse the two, and we'll get into CPAP later in the airway chapter, but don't confuse the oxygen administration part of CPAP with the PEEP settings. So the PEEP settings will start low and we can gradually increase those, but typically the oxygen setting is one number and it's whatever the delivery, whatever that particular device says. Okay. Any contraindications for oxygen?
Patients with COPD, you don't want to over oxygenate them.
Okay.
They're breathing normally.
Breathing normally is a contraindication of oxygen.
Non-hypoxic patients.
Non-hypoxic patients. You guys.
That was
all
actually
right.
in the book.
Yeah, I know. Define non-hypoxic patient.
Somebody that's breathing at 96% on room air.
Okay.
Or 96%. Oh yeah, 96. Was it SaO2?
Okay. Is that the only definition for a non-hypoxic patient?
That is my definition, though.
Remember though, with patients, just because they have good oxygenation,
They're
if it's a late sign, doesn't mean that they're having good ventilations. So just keep that in the back of your mind.
Yeah.
that
So
and I got a brain fart.
if you're
That's where
going to
end title comes in at.
Meal beds.
Yes, in title. Yep.
all right. So if we're going to define a non-hypoxic patient, SaO2s over 96 and higher is one thing. We also want to look at CO2 levels. We also want to look at respiration rates and respiration efforts. So if the patient is in that 12 to 20 range, if they're an adult, if they are having an O2 set at 96 or higher, if their CO2 does fall in that 35 to 45 range, and if they don't have any complaints of difficulty breathing, and they're not showing any signs of labored breathing, then we would say, okay, they're non-hypoxic, and we really don't have an indication to give them oxygen. So it's quite a bit to look at. There's a lot of little moving parts here, but yeah, there's plenty of people that we don't need to administer oxygen to. It's only contraindicated in a couple of cases. So, and contraindication maybe isn't the right word. It's like used with caution. So the COPD people, we're not going to withhold it. We're going to use caution, and we're going to administer it in small steps. Also be careful with hyperventilating and doing those types of things with it in certain cases, but typically not very much in the contraindication world. Nobody's allergic to oxygen, so hypersensitivity is not an issue. Anybody have anything else on oxygen?
One of the side effects is drying of mucous membranes.
Yeah, that's what sucks about the nasal cannulas, especially nasal cannulas at 6. Anybody that has to run a nasal cannula at 6, you should probably switch to a mask. All right. What's next?
Epi 1 in 1,000.
Epi 1 to 1,000. Okay. What's another name for epi?
Epinephrine.
Okay. What's another name for it?
Adrenaline.
Adrenaline. There you go. Adrenaline would be the brand name. Epinephrine is the generic name. So adrenaline would be a brand name for it. Epi 1 to 1,000. What is the indication for use?
Acute anaphylaxis.
Okay. Anaphylaxis. What is the dose and route?
0.3 to 0.5 milligrams to adult.
Yep.
And the route is going to be in IM.
IM. Yes. 0.3 to 0.5 milligrams. IM is the adult dose. What about pediatric dose?
0.01 milligram, or is that milligrams? Yeah, milligrams per 1 kilogram up to 0.3 milligrams.
Okay. So 0.01 milligrams per kilogram is the pediatric dose, up to 0.3 milligrams total. And the route for the pediatrics?
That's going to be IM as well.
Okay, that's also IM. All right. So epinephrine 1 to 1,000. Indication for use is anaphylaxis. That is, we covered the adult and pediatric dose. Contraindications?
Patients with underlying cardiovascular disease, hypertension, and pregnancy.
Okay. What does epinephrine do to the body?
Speeds it up.
So Heart rate is an issue. We need to be careful with people that have very high heart rates. Does anybody know what the dosage, what happens to the dosage as people get older?
It goes back down to like a pediatric dose. It gets decreases.
Right. So in a lot of cases with the elderly, the dosage would be cut in half because of the effects it has on the heart. Anything else we need to add with 1 to 1,000?
If someone is on beta blockers, would that
How's
cause
that
some sort of complication? Because
how's that-
it would inhibit its action, right?
How's that going to work? Not in the but not in the allergic reaction world, right? Because this is a multi-system thing.
Oh yeah.
So we're not using. If we'll talk about it a little bit, that's more relevant in the 1 to 10,000. But with the 1 to 1,000, it's anaphylaxis, and we're looking at multi-systems. So we're trying to stop that reaction process. So it's not so much a heart specific potentiation here. So I would not be concerned with the 1 to 1,000 being inhibited by beta blockers. All right. One little side note, bonus question: what else can 1 to 1,000 be used for?
Bronchial asthma.
There you go. Brian gets the prize. What do we call that? Administration of epi that way. How is it administered?
Nebulized.
Okay. And what's the name for that? Do y'all know?
Ischemic epi.
Yeah, racemic epi. So
Racemic
that's
epi.
nebulized epi, and for severe asthma and breathing troubles. Usually in the protocol, racemic epi is way down the line in respiratory distress. Cool. All right. What about epi 1 to 10?
That's used for cardiac.
Okay. Specifically what at the A level?
A level of cardiac
Cardiac
arrest.
Cardiac arrest. What rhythm specifically?
VFib and pulseless VTAC.
Nope.
Asystole.
Asystole.
Asystole, because you can't shock asystole.
That's right.
Only thing you can do is
Yeah. So VFib and pulseless VTAC, our first treatment is going to be electricity for those. At asystole, then we're going to push epi 1 to 10. So cardiac arrest, what is the dose?
1 to 10,000.
That's the
1
concentration.
milligram repeated every 3 to 5 minutes.
Oh, my bad.
There you go.
Yeah.
1 milligram every 3 to 5 minutes.
That's 3 to 5 minutes.
Is there a max?
Until you run out.
There you
Right.
go. Until you run out or quit. What is the route?
IV, IO, or ET?
IV, IO, or ET.
Yeah.
And remember, if it's ET, we double the dose. So the dose will be 2 milligrams ET, where it's 1 milligram IV or IO. Okay. What's the adult? That's the adult dose. What about pediatrics?
0.01 milligram per kilogram.
Okay.
Max dose of 0.5 milligrams. And it's every 3 to 5 minutes until observed of response.
Okay. Any contraindications for this?
Yeah. If you're in cardiac arrest, no. I would say.
No. All right. Anything else we need to know about Epi 1 to 10?
Don't mix it up with 1-to-1.
All right. So we'll talk about that in the
They're not
labs.
cardiac arrest. They will be.
We'll talk about that in the labs. This medication, Epi 1 to 10 and Epi 1 to 1, it's the exact same medication. The only difference is the concentration. So Epi 1 to 1 is 10 times more concentrated than Epi 1 to 10. So that is the difference. All right. So what the last one was what? Diphenhydramine?
Yes.
Okay. What's the other name for that?
Benadryl.
Benadryl. And the dose?
50 milligrams.
25 to 50 milligram.
25 to 50, isn't it?
Yeah,
Yes.
let's go with that. 25 to 50 for the adult. 25 to 50 milligrams. What's the pediatric dose?
2 to 5 milligrams per kilogram.
Would ask that.
Who?
2 to 5 milligrams per kilogram.
That seems like a lot.
It's 0.1 milligrams per kilogram.
That seems like not a lot.
1 to 2 milligrams per kilogram.
Wait,
I
no,
like
it's
the-
1.
I like that one better. Let's go with 1 milligram per kilogram.
Yeah, 1 milligram per kilogram, max of 25 milligrams, not given to infants less than 3 months.
There you go. Now we're getting somewhere. Okay, so adult dose 25 to 50 milligrams. Pediatric dose 1 milligram per kilogram up to 25. Not administered in patients less than 3 months. What's it used for?
Allergic reaction.
Allergic reaction?
Allergic reaction. Allergies.
Okay. Specifically for what what symptoms specifically for allergic reaction?
Anaphylaxis.
Nope.
Yeah. Wheezing.
Nope.
Itching.
Itching,
Rash.
hives, all the skin stuff is the Benadryl. That is the intended deal with the Benadryl. If they are having skin issues, itchy, rash, hives, we will give Benadryl. If they are having breathing issues, we are going to give Epi 1 to 1. And in most cases, if we do Epi 1 to 1, we are also going to do Benadryl. Okay. What's the class of Benadryl? What is Benadryl?
Histamine.
Antihistamine. It's a H1 receptor agonistic.
There you go. It's an H1 blocker. So it's a antihistamine, and it's an H1 blocker specifically. You guys will get some H2 blockers later on. So do you know what an H1 blocker is? What its actions are?
Oh, shoot. I don't remember. Well, I remember, but I don't
And
remember.
it's something to do with the heart.
I love Brian. I love Brian, I swear.
I love you, Brian. Those are the alpha and betas,
Yeah.
but the ones are for the heart. H1s are these are the histamine blocking
Wait,
deals.
is it 2 lungs, 1 heart?
Yeah, that's for
Yeah,
the
that's the one I was talking about.
that's the alpha and betas.
That is alpha beta. Oh, I guess we're sharing a brain today, Brian.
Okay, so for the histamine blockers, the H1s are the quick acting, short lasting. So you'll see that's why Benadryl is the first go to, and then the H2 blockers are going to be the longer lasting ones.
Oh, wait, ipratropium's a H2.
Who?
Isn't ipratropium an H2?
No.
No,
No.
because that's long. I'm thinking of something else. Never mind.
Yeah.
Ratidine.
You'll get the H2s. What? Who said what?
Ratidine. Zantac.
Yeah. That's an H2.
Uh,
Zantac, Pepsid, those types of things. So you'll get those in a later list. H2 blockers, but
and they're H2 blockers.
Benadryl is an H1 blocker. So, all right. Any questions about Benadryl? What's a what?
Does it come in anything but grape?
Huh?
Does it come in anything but grape?
Yeah. It does.
It does.
How do we give it on the ambulance?
IV push.
Okay.
Yeah. Or liquid.
Yeah, we don't usually carry the oral form. We mostly carry the IV form or IV or IM form. What's the side effect of Benadryl? What do you expect your patients to do?
Make them sleepy.
Yeah, it helps them. Most people, it makes them sleepy. But be aware there is a small class of people that it does make hyper.
Yep.
So if you give them Benadryl and they turn into the Energizer Bunny, they are in a special class. It's not a terrible thing. It's just that small little group of people that actually get hyper, as opposed to most people that are going to be drowsy. Okay. Any questions about anything? We gotta get out of here. Get you guys on with your day. Does anybody have anything?
Nope. What's the test on Friday? That modules. What is it?
If you're testing Friday, you're making up module 1.
Right. Yeah.
That's chapters 1 through 6.
Right.
And then everybody has module 2 this week, which is chapters 7 through 10.
Okay. 7 through 10, module 2. Okay, that's what I thought. I just wanted to make sure.
Okay. So,
program.
all right. So, for everyone, the rest of the week, we have the lab sites. The 3 are open. Perquimans tomorrow night, Elizabeth City Thursday morning, and then Currituck on Friday afternoon. Please be at the ones you have signed up for and be ready for your module 2 exam, chapter 7 through 10. And then the lab is, once you finish your module exam, the lab will be on IVs. So we'll be showing you guys all about IVs, how to start them, whatever. In the meantime, make sure you're doing your online work, getting your chapter quizzes done, your medication list done, all of your little projects done. Don't forget to do your self-assessments each week and pick your next lab site as well. And then the great thing is no class next week. It's Thanksgiving week, so enjoy the holiday. If you're working, be safe. If you're not, enjoy some time off and family time and all that stuff. If you don't forget to get into the books. Keep reading, keep studying your cards, but get a little bit of rest and take a little break for us. All right. Yes.
Hello.
Hello.
The lab on Thursday, you said if it's 3-hour or 4-hour determines whether it's 8 or 9.
Yes.
What time is the class on Thursday? Because I don't find where it says 3 or 4 hours, or I'm skipping right over it.
It's in the syllabus.
Okay.
The syllabus lists lab hours is the middle column of numbers, lab hours, and it'll either say 3 or 4. So for this week, it's a 4-hour lab, so it'll start at 8.
It's 8 o'clock. Okay.
Okay. All right. Anybody else? If nobody has anything, good seeing you guys this week, and we'll see you in the labs. Y'all have a great day.
All right. This week.